All right, we're ready to start our next session, and I'd like to introduce Monique Hines, who will present on Telepractice for Quality NDIS, Allied Health Services, Evidence Informing Innovation.
Hi, my name is Monique Hines. I'm from the University of Sydney. I work with a multidisciplinary team of allied health researchers called the Wobbly Hub Rural Research Team. So I'd first like to acknowledge my colleagues Michelle Lincoln and Kim Bulkley, also our research partners at Therapy Connect, so Simone Dudley and Sue Cameron. And finally, we'd like to acknowledge some funding support that we've received from ORDA Foundation to support this research. Now, first of all, I'd like to clarify what I mean when I use the term telepractice. Now, when I use that term, I'm really referring to the real-time delivery of assessment or therapy services by an allied health professional who links in with a service user, whether that be a person with a disability, a parent, a teacher's aide, or any other significant person, via web-based video conferencing such as Skype, Adobe Connect, and Zoom. Now, our interest in telepractice has really emerged from some wider research that we've conducted that's really established that many people with disabilities living in rural and remote areas are simply not getting access to the allied health services that they need at the regularity and the intensity that they need them, especially once they get past early childhood. Now, we know that allied health has a critical role in supporting the participation and the inclusion of people with disabilities across the lifespan and across contexts, whether that be at home, in the community, in educational settings. And so what this means, without necessary allied health support, this has left many people with disabilities in rural and remote areas really vulnerable to a range of long-term poorer outcomes, such as reduced educational achievement. So telepractice has really emerged as having the potential of extending the reach of allied health professionals into these areas to equalise access to allied health therapy. Now, currently we see that telepractice as a service delivery model is becoming increasingly common, particularly in areas such as the United States. On the other hand, the research evidence is still in its infancy, but it's mounting, and it's certainly mounting in its favour. The problem is, though, that most of the research that we can see is mostly focused on telehealth for individual or single health issues, so things like stuttering or swallowing problems. There's very little information to go on in much more complex situations, such as we find in the disability space, where our clients are facing multiple complex health and rehabilitation issues. As a result, it's leaving disability practitioners with a number of unanswered questions. How can we deliver a service that is equal in quality to what we would normally do in a face-to-face setting? And we wondered exactly the same questions. So we conducted a research project to collect some preliminary evidence to address these questions. We did this in partnership with Therapy Connect. So Simone Dudley and Sue Cameron, they are an allied health professional, so speech pathology and occupational therapy, who provide services via telepractice, and they've been doing this over several years, so have really developed some expertise in this space. So we conducted in-depth case studies with them of how they provided telepractice to 4 of their clients. They were all children with complex disabilities. They were all new referrals to their service, to their practice, and we used case studies so that we could really unpack and get the information about the detail of telepractice processes. And we basically followed each child, each case, over 12 weeks and the services that they received. So we collected data on things like their achievement of therapy goals, the process data about the actual telepractice sessions, and we conducted interviews with the therapists, with parents and with teachers to find out about what they thought about telepractice. To give you some information about the children that were in this study, they were all aged 5 to 8 years. They lived in inner regional Victoria, but also remote and very remote Northern Territory. All children had a diagnosis of autism. They were all funded under HAQA or NDIS. And the sessions were used to target a range of OT and speech pathology goals, including self-care, fine motor, emotional and social well-being. Just to note, in each case in this study, the therapists had never actually seen the child or the family in person, either before the therapy block started or even throughout the duration of the therapy. So it was all completely done online. Where clinicians were able to use measures to measure achievement of therapy goals, we were able to find that children did achieve positive outcomes across a range of goal areas. Parents also told us that they noticed these improvements in their child's participation in home and school. Parents and teachers told us that they really felt more confident and felt supported in their ability to work with the child and help them achieve their therapy goals. And this is mostly because of that coaching approach that is usually adopted as part of telepractice. Teachers and teachers' aides who attended sessions told us that they found that by working with their child's therapist, they themselves were able to learn new techniques for supporting the child in the classroom environment, and that they found that really valuable. Beyond finding out about the benefits or the outcomes of telepractice, we also really wanted to find out more about what factors contributed to quality telepractice. What does it take to do a good job? What is it that the therapists are actually doing? We acknowledge in face-to-face therapy that not all therapy is good therapy, and the same goes for telepractice. So the great news is that from what we learned is that the hallmarks of what makes quality telepractice is really consistent with what we know about face-to-face practice. So we'd like to highlight 4 critical ones that we learned about in the space of this research. The first one is about person-centered practice. We learned that quality telepractice does not inhibit person-centered practice. This means that people with disabilities and their family members are still at the centre of decision-making about the services they receive, and it's this that drives selection of the components of telepractice. So for instance, in our study, people with disabilities and their family members could select where telepractice sessions happened, whether that be at home, at school, in some cases even at the public library. Some parents told us that they preferred sessions happening at home because they felt in that environment the child was much more relaxed, in a better frame of mind to work on difficult therapy goals. Other parents preferred it at school because it meant that it was easier to integrate therapy goals into the curriculum, or it also meant they could really maximise their child's energy levels by having therapy sessions in the morning at school rather than waiting till after school when the child was tired. Person-centred practice also really helped determine whether or not the clinician used a direct mode of service delivery, so engaging with the child using online activities, or whether the therapist decided to use an indirect approach, instead coaching a parent or a teacher's aide to implement a therapy activity whilst the therapist watched over video conferencing and provided feedback. And that was driven by considerations of what the child's needs were, what the child's preferences were, how they were engaged best, and what the therapy goals were. The second hallmark that we learnt about is the importance of therapeutic relationships in telepractice. We learned that telepractice does not impede therapeutic relationships. In fact, it's these therapeutic relationships that are a key factor that enable quality telepractice. So in this study, both the therapists and the parents and teachers told us that there were no issues in engaging children in telepractice sessions. In fact, some parents told us that they felt that their child was better engaged via telepractice than they may have been in a face-to-face setting. When children were difficult to engage online, then strategies needed to be used by parents, teachers, aides and therapists. For instance, they built on children's interests and kind of incorporated those into the therapy activities that were used. They used visual schedules in order to help motivate children and keep them on task. And then learning to change task when children's attention was lagging, or giving them an activity break as necessary. Now, these strategies aren't markedly different from what a therapist would normally do in an in-person setting. The difference, though, seemed to be in telepractice is that it really required the allied health professional to work with the parent or the teacher or the teacher's aide to implement these strategies. So what we really learn is that an important part of therapeutic relationships in telepractice is not just with the child, but more importantly with the supporting adult on the other end of the telepractice session. So working collaboratively with carers, parents, teachers' aides, was important because they are the agent of change, not the therapists themselves. So these supporting adults were implementing the therapy. They were being coached to learn how to use therapy techniques with the child. And to achieve this, the allied health professional needed to work with the parent or the teacher's aide to help them get resources ready for the session. So for instance, letting them know you're going to need to have Play-Doh ready or scissors and cardboard ready. Or alternatively, the therapist would need to email through to that supporting adult any materials that they would need to print up and have ready for the session. These supporting adults also needed to manage technology and work with the therapist to troubleshoot technology when necessary. This person was also the allied health professional's eyes and ears within and between sessions. So they were able to provide information to the therapist that they otherwise wouldn't have access to. So one example for that was when working on handwriting, the therapist preferred having the camera angle down at the child's hands and the paper so they could see what was happening there. But that meant that the therapist missed out on information about the child's posture at the same time. In that situation, the therapist needed to work with the parent who was able to give feedback on the child's posture during the handwriting activity. So the parent was able to do this verbally by telling and describing to the therapist what was happening with posture, but they were also able to do things like take photographs, take even video and send this via their smartphone to the therapist. So the therapist was able to get access to all the information that they needed at the time. From what we learned from this study, we learned that it's not about the technology. It's actually what's more important is knowing how to use technology as a vehicle. So we learned that parents and therapists, they don't need specialised equipment and they don't need particularly advanced skills with technology. The technology platforms they used were desktop computers and iPads and Skype and Zoom, nothing really specialised. Also, we learned that internet connectivity was not always great, but this was not a deal breaker to families or schools. They expected it and were ready to work with therapists to address these sorts of issues. In our study, we had 43 billable occasions of service, and really there was only one session that needed to be completely cancelled due to problems with technology. The majority of time where there were some issues with technology, they were able to troubleshoot and work around this and make a go of that session. So what we learned is that what therapists need is a willingness to learn new technologies or functions. So the ability to Google how to screen share or how to develop electronic resources. Therapists need to know how to troubleshoot technology and have a plan B or a plan C ready to go. And they need to have the ability to support families and schools to troubleshoot technology as well. Hopefully it's becoming very clear that the critical component that makes telepractice work, far from being about the technology, is the skills of the allied health professional. So we've really found that strong professional skills are the critical ingredient. Now looking at these skills that we found evidence of, they're not markedly different again from what we expect in an in-person setting. Therapists need to have strong communication skills because therapeutic relationships which are underpinned by strong communication are what make telepractice work. Therapists need to be good collaborators to be able to develop the connections and the relationships with people in the child's environment who can help you make things happen for that child because you're not in that environment. They need to be good problem solvers, the ability to think outside the box so that they're able to achieve therapy goals without actually being there in the environment. They need to be prepared, have a clear plan of what is going to happen in the session, have the resources ready to go, and be able to work with parents and teachers' aides to be prepared to have resources ready and on hand as well. It also means having prepared a backup plan so that you can flexibly change online in a session in case you need to have a change of approach. So I guess in summary, we learned that telepractice has a lot of potential to enable access to allied health services for children with complex disabilities in rural and remote areas. We know there's still lots of unanswered questions and lots more for us to discover. For instance, are there service delivery models that involve a combination of telepractice along with in-person face-to-face sessions or working with allied health assistants that might be even more effective and more appropriate under certain situations? We know that telepractice might not be right for every client all the time, but we'd really like to see it as part of every clinician's toolkit that they can use when necessary and when that's best suited to clients' goals. So in line with that, we've tried to produce some practical resources and that can actually help clinicians give this a go and help them make telepractice a success. So please feel free to get in contact with us and go to our website. We've there got some guidelines about telepractice, and very soon we'll have a video about telepractice that you'll be able to download to find out more about this topic. Thank you.
All right, so I think we're ready to hear some comments from Monique and from Simone. If you can share your webcam. And we also have some questions for you. Hi, Monique.
Hi, how are you?
Good. And there's Simone. Hi, Simone.
Hi there.
Oh, good. We can hear you just fine. That's perfect. All right. So our first question that we have is, does the NDIS, I think this one's for Monique, does the NDIS consider telepractice for allied health to be an effective engagement method, and will they accept billable hours using this tool?
Yeah, absolutely. It is an acceptable way of delivering services under NDIS. So there is no separate price structure for services or supports delivered via telepractice versus traditional in-person services. So it uses the same line items, and I guess it really reflects NDIS's acknowledgement that in order to, technology and innovative use of technology as being a really critical component to increasing the opportunities for people with disabilities and the way in which services are delivered. Perhaps, Simone, if you would like to comment on what your experience has been in terms of registering for NDIS and that side of things.
Certainly. So we're registered nationally across Australia with the NDIS. That's been fine. They totally accept telepractice. But there have been some challenges around participants finding our services because the provider search portals are all location-based, and that's been quite a challenge when you provide an online service. So, yeah, we've had to go in and type in lots of locations for our services manually, which has been probably a bit of a frustration.
Okay, and another question for Monique. So the asker says, "Thank you, Monique, for a great presentation and interesting research. Do you know if there is specific guidance from the NDIS regarding what is or what is not billable telehealth service in the NDIS?" So I'm not sure if that was NDIA or NDIS.
So I don't think there's any specific guidance around that per se, but just as, when we're making a justification for delivering any sort of disability service or support, as long as the telepractice is working on those specific outcomes that have already been pre-identified, then I don't believe, Simone, you haven't had to justify telepractice as a delivery medium, have you?
No, we certainly haven't had to justify it as a medium. I'm just wondering if the lining of the question is relating to time spent outside the session time, perhaps. And if that's the case, then that's up to the service to look at their model of practice and how, we only bill for our session times, and so all of the work that goes in behind the scenes is just factored into our service delivery model.
Okay, and Simone, there's one for you. Is telepractice suitable for all disabilities?
Oh, that's a really good question. So I'm going to let Monique answer this one as well, but from my point of view, outside the scope of this research, I do work with physical, intellectual disabilities, but probably what's really important to note is I only work in the area I believe that I have got competency in. So if there's a referral for a job that I feel I haven't got the skill set for, then I can't be taking that client on. And I think that that's probably the point here. So in essence, working with a range of disability is really the same process. It's all about goal setting, collaborative problem solving, and perhaps there might be some times when you might need to recruit some asynchronous methods such as video recording of the environment, of posture, and supplementing that within your therapeutic program. And the other note that I would make is that I feel that if the clinician has the experience and the competency, chances are they might underrate what is possible via telepractice. So in my opinion, there's always more that can be achieved than what you initially think.
So just to add on to what Simone was commenting on there, obviously our research was limited to children with autism. So it is hard to determine the degree to which how effective and feasible telepractice is to other client groups. I'm thinking particularly complex physical disability, so wheelchair prescription and things like that. As Simone said, it's entirely possible that with different disability groups, we may need to, bring in a different configuration of components. So, in which circumstances is it better for us to work in tandem with an allied health assistant, for instance? So maybe the clinician Skyping in or using video conferencing to deliver a service, but working in collaboration with an allied health assistant who is there in person with the person with a disability. Maybe in some cases it's completely appropriate to have some judicious use of in-person services, maybe at assessment points or at critical transition points, then that's going to enable an effective therapy provision. So there's definitely, I think, a need for more research around this. I do know at the moment Ed Johnson, who is a PhD student here at the University of Sydney, he's currently also trialling telepractice with some children who are non-verbal and around AAC service delivery as well. Although he hasn't published any of his results yet, it's definitely emerging that it's feasible and it's looking like it's something that's going to have a place for service delivery within different specialties and different client contexts as well. So we definitely need more research around this though.
Wonderful. Okay, there is another question for Simone. My understanding is that NDIS, NDIA expect a face-to-face engagement. Is this not the case?
This is not the case. So we have clients all over Australia and they are NDIS participants, a range of plan-managed and self-managed clients, and there is no requirement for the family they will accept telepractice. So bearing in mind that these are children that largely are diagnosed, they've had assessments, so we are picking up with pre-identified sort of therapeutic goals and we're working with families on achieving goals.
I think with that, some of the concern that sometimes is voiced by some specialists or some professionals is the concern that telepractice impedes the ability to work on goals around inclusion and participation. I think there are a lot of attitudes or assumptions that engagement has to happen in person for it to be quality. And I think that's the place of our research here, is to kind of give some evidence that actually these sorts of outcomes in terms of engagement, both with people with disabilities as well as carers, can be developed in an online forum, in an online medium. It also requires a skilled clinician to actively plan around how to work on inclusion and participation, so that you're making sure that you're looking at generalisation of what is done during the session in an online medium how is that generalised into that child's everyday environments outside of the telepractice session. Thought it was really encouraging in the panel discussion that we had just previously, the work from Jen Gallup, who really alluded to that same thing, that the skills that children were learning in online games and gaming were generalising to their face-to-face context. And we see a really similar pattern here happening in telepractice as well.
Okay, do you have fails delivering services by telepractice, and how do you respond to them?
I'll let Simone answer that one.
Well, sure. You know, from time to time you have fails in a telepractice session in the same way that you do when you're in a face-to-face setting. So you ask yourself, you know, are my skills right? Have I sort of pitched the just right challenge with my client? Is my sort of rapport building skills? You're sort of questioning yourself all the time. I guess the difference with telepractice is that you're so vested in making it succeed that you are working really hard, and you've got the technology challenges as well. So fails definitely can happen, and how I respond to the fail is that perhaps I need more information about the environment or the client. Sometimes I think, well, that's part of innovation too. Having a fail and trying new things is about pushing the boundaries. So I accept that you can't expect to innovate without some fails.
And I think from what we've learned by working with Therapy Connect is it seems that where it would fail, maybe it's rarely due to one single factor. In our study, the clinicians were generally able to problem solve around problems with technology, with families who hadn't engaged with therapy before, with families who are from non-English speaking backgrounds, and so on and so on. So it's rarely going to be one factor. Usually those things can be worked around. I'm guessing, it's my hunch that it's really a series of factors, a combination of factors is what would kind of lead to a situation where telepractice isn't going to be viable, and you're going to have to look at other ways of delivering supports to people who need them.
All right, and I wanted to share one final comment here from a participant. As a parent, I have utilized telepractice to access allied health services. Whilst the client was neurotypical, the quality of the service was just as good, if not better, but had the added benefit of completely removing the travel and time scheduling demands for the family. Families are flat-strapped and benefit from any initiative that decreases pressure. So great to hear the progress that is being made in this area.
Oh, that's such a beautiful comment to hear. It's something that we've heard echoed time and time again from families. And I think families are actually the ones who seem to be much more supportive and much more ready to give this a go than perhaps the professional world. So it would be really great to see families more and more finding this out as a legitimate option so that they can really demand for it, or, you know, ask for these sorts of services if they need to.
Yeah, and here, as a rural and remote clinician, as well as, I guess, user of medical services, you know, it's just so exciting to think that telepractice can offer increased access to a service that means you don't need to have, you know, a day or two off work and out of your routine, out of school, to be able to access.
Thank you both so much for your time and your information. And Monique, thank you for your presentation as well. Simone, I'm glad we got your audio working. So thank you both so much. And we're going to be moving on to our next session.